Like, I'm only do breakfast blends because I tried like bold and it's just too aggressive, even with her. Yeah. Like, and
And it's crazy you gave us this, because this is what the girl from Glasgow, she had these,
Really?
yes. And I was like, we should do this, we should get that. And I was like, cool.
Where's ours? There's
Yeah,
no
right
number
here.
two, I should have.
No, she had the ghost one, but she also had it with, images, like sonographic images. And it would be like pathology and non-pathology, like, and different things that she could fill in. I was like, that's awesome. I thought she just was like cool and typed her notes up like really. I'm like, did you do that? She's like, oh god, no. I'm like, okay, perfect. Awesome. Like, I don't know what they got going on over there, but,
Where's this?
I wanna say HP. Not UNBC, not H, I was like, HBCU, is that?
No.
I'm thinking of food.
It's a community college.
Yeah.
Oh.
It's not like- She was cool, I like her. I felt so excited when I was
UNBC, and me too. She didn't know anything.
Yeah.
It made me feel great. She's like, what have you scanned? I was like, everything. What have you been scanned? Nothing. I think the aorta, I'm like, oh, very, so nothing.
Alrighty. Vascular supply, liver vasculature. I know, beautiful. It's my wheelhouse.
Yes.
The vasculature for liver is really not that complicated. You only have three main players. You got portal veins, hepatic veins, and hepatic arteries. Of those three, which two are hepatopedal, which one is hepatopubal?
Have a pedal, portal vein, and hepatic artery.
Correct, yep, so those two portal veins and hepatic artery, they're part of that portal tribe, bringing blood flow into the liver. So those are the two vessels that are responsible for our vascular supply for the liver. And then the hepatic veins are responsible for drainage of that liver, so what goes in must come out. So the portal veins, they bring the nutrient-rich blood from the digestive organs to the liver for processing and storage. Really hard to read that blue. And make it darker.
I think it might be, maybe they'll break window. But I
Those-
don't know.
You know what, I can change it on my thing here. Whoop, let's go back. It's not a good font color. Red? What should make it black? Black. There you go, black you can read. White, red, white's the best color, I think.
He's fun. Like, we're bringing it back to.
got all my pen.
I have some pens.
I usually have pink and blue and dark blue.
I don't really weird. Oh, you're weird. You don't like a ball tip? A ball? No. Oh, you're weird.
I like my.
You like the thin weird one?
Velocity pen.
No thanks.
So
I appreciate it. Thank you.
portal veins are more scanning portal veins. We see the portal vein, it's large, significantly larger than the hepatic arteries. So when we image the portal vein, we start getting the picture of the main portal vein. It's a nice big juicy vein. So it just makes sense that the vast majority of blood flow that's destined, and that enters into the liver comes via that portal vein. So about 70% of the total blood volume that goes into the liver is via the main portal vein. So they say about 2/3, 70%. The remainder of that is via the hepatic artery. The portal veins, they're interlobar, so they run within the lobes. Or intersegmental within the segments of the lobes. The characteristics of the portal veins, they have smooth echogenic walls that contain fibrin. So it makes them pop, so they really stand out when we're scanning the liver. So portal veins have those thicker echogenic walls that make them stand out when we compare them to the hepatic veins. So that's how we can identify portal veins versus hepatic. They refer to portal veins as running horizontally. So as it enters into the liver, it branches and they run horizontally through the liver. Whereas the hepatic veins they refer to as running longitudinally, kind of up and down. So you can see kind of how they disperse through the liver. They disperse horizontally across the liver, whereas hepatic veins are longitudinal, running up and down. So the main portal vein, we know is formed at the portal confluence, by the head of the, pancreas, by the splenic vein and superior mesenteric vein coming together. So main portal vein is formed by the union or coming together of the superior mesenteric and the, splenic veins. It approaches the porta hepatis where it enters into the liver in a rightward and cephalic or superior direction. I'm sorry, so rightward cephalic and slightly posterior. Yeah, so it's superior towards the right and in a slightly posterior direction, so it runs getting a little, but the porta hepatis is a slightly deeper, so it comes. That doesn't make sense. It should be cephalic and slightly as it approaches porta hepatis.
Just gotta switch them.
Yeah, so it's,
I see what you're saying. Makes sense, just was written weird.
yeah. So it's rightward cephalic and slightly anterior actually.
The arrows.
That's hard to see too on there. That's what this blue. Just to right. So it lies within this hepatoduodenal ligament. The important number that we need to memorize for main portal vein, and aside from the direction of the flow, is the diameter. So it should not exceed 13 millimeters. So what's that converted to centimeters?
1.3.
1.3, good. 1.3 centimeters, 13 millimeters. So once it enters into the liver, it starts to taper a little bit, so that diameter decreases. Distal to the porta hepatis, or proximal, or the origin is back near the pancreatic head. And then it starts to taper once it enters into the liver and then branches into your right and left portal veins. The portal system, it comes in contact with the anterior surface of the IVC near that porta hepatis. It doesn't connect to the IVC, but comes in contact with it. We can use the portal system or the main portal vein in locating the hilum of the liver. Main portal vein then divides into two branches. We have a right portal and a left portal vein that bring blood flow to the corresponding lobes of the liver. So we're kind of looking at the liver here now, so you can see right kidney, kind of get your bearings, right lobe of the liver, left lobe of the liver, the main portal vein entering before the hepatis, and then branching into your right and left portal veins. So typically the right portal vein is the larger of the two branches. The right portal vein then further subdivides into a right anterior portal vein and a right posterior portal vein. Then bring both to those corresponding liver segments. So an ultrasound, here we can see, so this is more of a transverse view. So when we're scanning, doing our transverse sweep of the liver, we got our IVC here now. As we're coming down, we can see that right portal vein as it's coming across the right lobe of the liver. Left portal vein divides into the left medial portal vein and left lateral portal vein. Sonographically, this can be seen as this, what's called a steer sign. So you can see that left portal vein branching into that medial and lateral segments. Other CT image showing our portal system. With my eyes, man. I don't know if it's just that colored. So the other veins that are, associated with the liver are gonna be our hepatic veins. And now this is responsible for the venous drainage of the organ itself. We know that we have three hepatic veins, right, middle, and left, each draining its corresponding liver segments. And they drain or empty into the inferior vena cava, transporting the deoxygenated blood from the liver back to into the systemic system for oxygenation. The hepatic veins, they lie interlobar between the lobes of the liver or intersegmental between the segments of the individual lobes. So the hepatic veins are utilized to divide the liver, we said, into segments. So the middle hepatic vein divides the liver into right and left lobes. The right hepatic vein is the largest, and the left one is technically the smallest. We know that they converge, like I said, they're draining the liver, converging and draining into the IVC. A lot of people will have the left and the middle come together and kind of form like a common base or common stalk. We've seen, as you guys have scanned each other, you all have different presentations, different branching patterns. So again, yours might have more additional branches. Your left one just might be independent and not converge with the middle. So in terms of the hepatic veins, these vessels do not have that same fibrous echogenic wall that the portals do. So sometimes they refer to them as being naked or borderless without borders. So I can see in this picture a vessel over here that has the bright echogenic walls, and just adjacent to it, another anechoic structure that likely represents now hepatic veins. So we've got portal veins and hepatic veins kind of side by side. And you could use, again, those walls to help differentiate, the two. In addition to that, you can also use the flow patterns, whereas these are going to be draining, longitudinally, and the hepatic veins are going to be running horizontally as well. So you can kind of see the way they course as well. This one's a little bit harder to see, but you can see some little structures in here with these bright echogenic areas. So those probably represent portal veins as they're coursing through the liver, which makes sense, that they're running kind of like crisscross to each other. So when I'm seeing these elongated, those are going to be transverse and vice versa. So if I'm elongating the portal veins now, the hepatic veins are going to look like transverse. So vessel walls are not echogenic because they have a very minimal amount of collagen in them. The flow pattern in hepatic veins, we refer to it as a multiphasic. So it takes this W-shaped appearance to it. And there's a momentary period where it actually reverses in the opposite direction. But in general, the flow pattern is hepatofugal. It's draining out of the liver or flowing away from the liver into the IVC. That's the overall general flow pattern. They get larger as they converge and approach the IVC, so the diameter gets progressively larger. Closer we get to the IVC. Here's a nice, I want to say sagittal, but opened up view of our main portal vein, going all the way from the pancreas, towards the head of the pancreas, all the way through the porta hepatis and into the liver. Get your bearings. So again, when we're looking now, we can utilize, again, we like to try and open up the main portal vein and use it as our landmark. locate the porta hepatis, and then we were looking anterior, just in front of, the main portal vein for our hepatic artery and bile ducts. Where So hepatic veins, we say that the flow pattern is multiphasic. So it's pulsatile because it has that close proximity to the heart. So the flow pattern looks like these little W's. And we get a momentary period above the baseline where it actually reverses flow. And then that's again due to atrial contractions. When the atria are contract, it pushes some blood flow back down the IVC when those atria are contracting, trying to force the blood, into the ventricles. Some blood does get pushed back down the IVC. So we wind up with these little periods above the baseline. So we get these little W flow patterns, systole, diastole, and the atrial kick or the atrial compression. So hepatic veins are very distinguishable. They're a Doppler flow pattern. That's our hepatic vein flow pattern. That's what we look to see. When we get into vascular 3, we'll learn about like deviations from that, what pathologies could potentially be indicated, but that's our normal Doppler flow pattern for hepatic veins. And then for portal veins, so this is hepatic veins, hepatofugal, multiphasic portal vein. Monophasic. Slight respiratory variation. So the main thing with the portal vein now is we want everything above that baseline flowing into the liver. So everything should be above that baseline, so some of you, well, that might just be pulled in, depending on the patient, You just want to make sure everything is above that baseline. You could see, you should be able to see a little bit of respiratory variation to it. With this guy, it's okay if it's kind of flat. You guys are so young, so your portal flow is, it's rocking, it's moving. The older you get, the more it slows down. So you might have patients where you could just get a flow just above the baseline, kind of hugging it. But as long as it doesn't, reverse on you at any point, that's good. When we start looking next week or the subsequent weeks when we're talking about portal hypertension, we're going to be looking at changes to that portal flow. So just kind of get an idea. You can know right away, am I Doppling a portal vein or a hepatic vein because the waveforms are so vastly different. Hepatic veins, we said, again, multiphasic. you got that momentary period where reverses looks like W's and then. Portal vein looks like our normal or more traditional venous flow. Vascular supply. So the best way to distinguish between hepatic veins from portal veins is to trace their points of entry into the liver. Hepatic veins will flow into the IVC. Portal veins arise from the confluence of the splenic and superior mesenteric veins and enter into the porta hepatis and then branch outwards. Yeah, in addition to that, we said we could look at the vasculature itself, the way it's coursing through the liver. You know, is it running longitudinally or is it running transversely or horizontally across the liver? Do they have the bright echogenic walls or does it look like they're borderless or without the walls? This is a longitudinal image showing the IVC. The inferior vena cava with the main portal vein in the picture, so we can see that IVC coursing posterior behind the liver. We can see the main portal vein there. And we can also see hepatic vein as it's coming downward, you know, again, running longitudinally up and down and draining into that IVC. Kind of a chart breaking down, then. Portal veins are larger at their point of origin. Hepatic veins are larger as they drain into the IVC. In terms of the course, portal veins are intralobar, so they run within the lobes, or intrasegmental, so in the segments, they run in the lobes themselves, in the segments, whereas the hepatic veins are interlobar, so they're between the lobes and between the segments, so they separate the segments and the lobes, while these are running within the lobes and segments. The hepatic artery, so the common hepatic artery originates off the celiac axis. We know that's one of the three branches of our celiac axis. What are the other two for celiac?
Oh, wait, no,
Right,
oh, celiac, splenic.
Splenic
I'm
artery.
thinking what's
I'm
the
saying
letter.
splenic,
I'm
and you're
like,
saying that, and I'm
wait,
like,
Our
I'm thinking-
celiac
I'm like,
axis
wait,
coming
wait,
off,
wait.
our celiac trunks.
Oh, there's
That's
sure.
the splenic artery,
I'm like, that's
left
splenic.
gastric artery, and then the common hepatic artery. And then the common hepatic artery has
I was like, wait.
additional branches now. We got like our gastroduodenal artery heading down towards the head of the anchors there. We got the proper hepatic artery. That then is the one that enters into the liver. So common hepatic artery originates off the celiac. We then get branching and splitting, gastroduodenal, and the proper hepatic, which is the one that then enters into the liver at the porta hepatis. That proper hepatic artery then further divides into right and left hepatic arteries. Typically the middle hepatic artery is a branch off the left or the right, so it can be either one. It just depends on the patient's anatomy. So in terms of vascular supply, hepatic arteries, they carry now the oxygenated blood from the aorta to the liver. So we said portal vein is nutrient-rich blood. Hepatic artery now is the oxygenated blood. So again, it's a organ, it's a living tissue, so it needs that oxygen supply in order to survive and function. So it gets that oxygen supply from the hepatic arteries. Again, about 30% of the total blood supply that enters the liver is via the hepatic arteries now. In terms of flow pattern, this is an organ, so it should have a nice low resisting flow pattern. It should be similar to kidneys. It should be similar to ovarian flow. It should be similar to testicular flow when you get into that. Similar to our carotid arteries when we start looking at the ICA versus ECA flow. So again, these are all, any blood flow really that's going to any vital organ. Will have this low resistant flow pattern, so it's gonna be monophasic, a lot of diastolic flow. A very low RI, low resistive index. Normal diameter of the proper hepatic arteries, the one that enters into the liver is about 2 to 4 millimeters. You know, for me, you don't really have to memorize that number. Just understand the flow pattern and the direction. It's hepatopedal, so it's flowing in the same direction as the portal veins. So that's important, particularly when we get into portal hypertension. We're looking at that flow direction of the portal veins. We can use the hepatic arteries as kind of our baseline because they should be both flowing in that same direction and they course side by side as they're running through the liver. So they're parallel. They're, think of like a highway, a 2-lane highway, or just think of a road. They both go following each other, paralleling each other, but both going in that same direction. With hepatic arteries, they don't reverse. So that should always stay hepatopedal no matter what. Really what changes is the resistance. So again, is that when we start learning about pathologies, liver starts becoming fibrotic or fibrosed, we get higher resistant flow in that hepatic artery. So it's less and less blood flow. So as you understand, when we start learning about cirrhosis, it's a progressive disease. It just kind of snowballs on you, gets worse and worse and worse. So the less blood flow it's getting to the liver, the worse disease it's gonna get, the more fibrotic it's gonna get. And the less flow it ultimately winds up, and that's why it becomes, a fatal condition. This was a good example, showing the main portal vein and the hepatic artery, and they're buddies. They're part of that portal triad. That consists of the bile ducts as well. But again, they should be flowing in the same direction, here. So this is showing something that's not right. We see the main portal vein is blue, hepatopedal flowing away from the transducer, and hepatic artery red coming up towards that transducer. So this would be an example of someone that has most likely portal hypertension and flow reversal in that main portal vein. So again, hepatic artery, we're looking anterior to our main portal vein, so this is not more of a transverse view of it. Our main portal vein, that kind of Mickey Mouse sign where we got a bile duct, a hepatic artery. This is where, again, we're gonna be looking for CBD when we wanna measure it, trying to open it up, looking for our possible candidates. It's gonna be right at that, basically that same level as the hepatic artery. Blessings. So portal triads. So it's composed of 3 major tubes or three structures. So our hepatic arteries, our portal veins, and then the bile ducts. So the hepatic arteries bring that oxygenated blood to the hepatocytes. The portal vein brings blood from the portal system, that nutrient-rich blood, to the liver for filtration. And then the bile ducts transport the bile products into the digestive system. So we know the biliary system, the biliary tree now. So we're going, again, opposite directions. This is kind of showing portal vein, hepatic arteries flowing in one direction, bile ducts flowing in the opposite direction. The primary functions of the liver. So plays a role in metabolism, plays a role in digestion, and then as well as storage and then detoxification. So those are going to be our major, primary functions of the liver: metabolism, digestion, storage, and then detoxification. So metabolism, is physical and chemical process whereby, foodstuffs are synthesized into, complex, elements. Complex elements are then transformed into simple ones and energy is made available for use by the organism. So we're gonna go deeper into each one of these. In digestion, we know that the liver produces or secretes the bile, which is important for digestion of fats. Bilirubin is a pigment released by red blood cells and is broken down, and is excreted in the bile. Liver also acts as a storage, so it stores iron and certain vitamins as well. And then we know that the liver has, detoxification function, so it detoxifies many drugs and poisons that enter the body, as well as waste products, the body's metabolic processes. The liver also manufactures plasma proteins, converts excess amino acids to fatty acids and urea, removes nutrients from the blood. It phagocytizes bacteria and worn out red blood cells, producing those bile pigments. Secretes bile into duodenum through the bile ducts for digestion of fatty foods. And it also manufactures heparin to keep the blood from clotting. And so metabolism. So carbohydrates or sugars, as well as fats and amino acids, which are the basic components of proteins, are transported to the liver via the intestines. The liver either chemically converts these to other compounds or processes them for storage or for energy production. So the liver is a major site for converting dietary sugars. So those carbohydrates that we eat are turned into glucose. The liver turns it eventually into glycogen. That glycogen is then stored in the liver when glucose is needed. And then the body will utilize, if the glucose is needed, it's then put from the liver into the bloodstream for usage. So this is kind of that cycle. So we eat sugars, gets broken down into glucose, transported to the liver. Liver turns it into glycogen, gets stored in the liver when it's needed. And then once we need sugar for, exercise, metabolic processes, it releases it, turned back into glucose, and then enters into our bloodstream. Oh, sorry. So in severe liver disease, unless glucose is administered intravenously, hypoglycemia can occur. So when the liver is damaged, patients will become hypoglycemic. Their blood sugars are going to be very, very low. Better color this. Okay. So just kind of think about it, patient's liver is severely diseased, it's not functioning properly. And it's not producing, or it's not storing, um. It's, it's not, producing, the glycogen, or it's not storing the glycogen. And it's not releasing that glycogen into the bloodstream to become glucose, causes, blood sugars to drop. If it's also severely diseased and it can't take that glucose that's in that excess glucose that's in our bloodstream and convert it to glycogen, it's gonna keep that extra blood or glucose in our bloodstream, causing hyperglycemia now, so elevated blood sugar levels. So both can happen, when disease is present. So basically, if you have liver disease, you're fasting, you're not eating, you know, in normal conditions, when you're fasting, not eating, your body's still getting the sugar it needs, the glucose it needs for normal metabolic functions from the liver. So it's tapping into the liver and be like, hey, my sugar's getting low. I haven't eaten all day. It's tapping into the liver, getting the sugar that it needs in order to function. But if the liver's diseased, it's going to cause you to have very low blood sugar levels, because it's not functioning properly. Um, if you've eaten a lot, and you have excess blood sugar in your bloodstream now, and you've got liver disease, the liver is not functioning properly to convert that excess, glucose into glycogen for storage in the liver. That's going to cause your blood sugar levels to spike. Um, Liver is also a major site for metabolizing fats as well. So dietary fats are converted in the hepatocytes to lipoproteins, the form in which fats are, transported throughout the body for storage or use. Stored fats may be transferred to the liver or converted into energy. That red. Um, red. So the stored fats are transported to the liver and converted into energy. This yields substances like glucose as well as cholesterol. So again, the body can utilize cholesterol for energy as well. So fats are metabolized in the liver and absorbed, from the intestine in the form of, monoglycerides, diglycerides. Fluid's killing me, man. I read this at all. See it on my end. So those dietary fats can then be converted into the lipoproteins, um, which the body can utilize, which are either stored or used by other organs. So start of fatty liver disease. So when the liver fails to convert fat to glucose, it builds up in those hepatocytes. And this leads to fatty liver disease. Fatty liver is a non-specific finding. It can be seen in many conditions such as viral hepatitis, alcoholic liver disease, obesity, diabetes, pregnancy. So when there's excess, fat that's getting sent to the liver's going to take that fat and convert it to glucose, and then builds up in those hepatocytes, and that's what ultimately leads to the development of fatty liver disease. So sugars can be absorbed from the blood in several different forms. So it's things like glucose, like sucrose. Um, but only glucose is the one that can be utilized for the cells for energy. Excess sugar is converted by the liver to glycogen, which is a starch, which can either be stored in the liver or transported in the blood to distant storage sites. When dietary sugar is unavailable, the liver converts the glycogen back into glucose and then releases it into our bloodstream. So this can also manufacture glucose, and the liver can also manufacture glucose directly from proteins and fats as well. So the liver could take those proteins and fats and manufacture glucose. It can take it from storages that it already has, turn that glycogen back into glucose for the body to be able to use. All right, so albumin now. So albumin is a protein that is produced in great quantities in the liver. The functions of albumin acts as a transport medium in the bloodstream. It draws water into the vascular system. So it contains oncotic pressure, also known as a colloid osmotic pressure. So this, again, this albumin, this protein, basically allows for water, the water molecules to transport in and out of the vascular system. So it can draw water into the vascular system as well as pull water out of it. So albumin, can be utilized and also, involved in controlling blood pressures throughout the body as well. This can lead to things like, ascites, edema, when we see patients that have fluid in their, within their abdomen. The liver is also primary source of proteins that are needed for the clotting of blood. So the two main proteins that the liver produces are fibrinogen and prothrombin. So both of these proteins are necessary enough for blood to coagulate, form into clots for the red blood cells to stick together. Without these, we become, say, hemophiliacs. We'd essentially bleed out every time we're cut, or anytime there's any sort of vessel damage or destruction, would cause uncontrolled bleeding. So decreased production of these proteins may lead to, again, uncontrolled hemorrhage. So it doesn't necessarily have to be, you're just bleeding out onto the table. You've got internal bleeding, gastric bleeding, GI bleeding. Again, this occurs mostly in the bowel as a result of dilated veins or the development of an ulcer, and can often lead to immediate or contributing factor or cause of death. The administration of vitamin K may improve the coagulability, but this is just temporary. All right, so fibrinogen and prothrombin. So some of you might have seen some of those tests where they test your prothrombin time, how quickly your blood clots. Has anyone donated blood? That's one of the things that they check for when you're donating blood. Yeah. So they took the drop of the blood and like in that little test tube vial, and like if like you see it like kind of like drop or they're checking to see like how quickly your blood clots. The blood test can determine the clotting factor of the blood. So like I said, there's this prothrombin prothrombin time or a partial prothrombin time. These represent the amount of time in seconds required for coagulation steps to occur in a patient's blood compared with normal blood. Sometimes it's represented as an INR. So international normalized ratio. When patients have a lower value, a low INR, they have quicker clotting. If they have a high INR, it's a longer clotting. Hepatic enzymes. So enzymes are protein catalysts that are used throughout the body for metabolic processes. Because the liver is a major center for metabolism, large quantities of enzymes are present within the hepatocytes. When liver cells are damaged or destroyed by disease, these enzymes can potentially leak back into the bloodstream. So when these enzymes are leaked back into the bloodstream, that's when we refer to it as elevated liver enzymes or elevated LFTs when we get into those liver function tests. So again, we can kind of use these, presence of these hepatic enzymes in the elevated state to determine, that there is some sort of liver cell damage that's occurring. So the presence of increased quantities of enzymes in the blood can act as an indicator for hepatocellular disorder. So the ones specifically that we look for are AST, there's aspartate aminotransferase, ALT, alanine aminotransferase, and then the alkaline phosphate or ALPHOS. So blood levels, serum levels of all three of these enzymes are increased in both hepatocellular disease as well as in biliary obstruction. Patterns of elevation may help to differentiate between potential various causes. So again, collectively, this is what we refer to as liver function tests. And when we say elevated LFTs, these are the liver enzymes that we're referring to with those liver function tests. So the breakdown of red blood cells, the function of the liver helps when red blood cells are damaged and need to be broken down. That breaking down red blood cells produces bile pigments. That's when patients who have potential issues with elevated bilirubin levels. Bile is the secretion through the bile ducts through the duodenum. So we know the liver produces the bile, which is needed for digestion of fats. It's transported through the bile ducts into the duodenum. The liver function for amino acids, it converts urea and glucose. Carbohydrates, it converts glucose into glycogen. It converts carbohydrates, it converts carbohydrates into glucose, as well as convert the glucose into glycogen. So it manufactures from glucose, creates glycogen, and then that's stored in the liver for future use. So the glycogen is the storage of glucose. I can then take that glycogen, break it down and convert it back into glucose, and then release it into the bloodstream for use. It's a major producer of heparin, which is needed to prevent the blood from clotting. So it does both. It creates those clotting enzymes that are necessary to prevent us from bleeding out, but it also creates the heparin, which prevents the blood from just clotting throughout our body. So it kind of has that nice balance, that homeostasis, between being able to clot just the right amount and keep those kind of blood cells together and keep us from bleeding, or versus us, the blood just becoming, thrombosed or clotting. It converts dietary fats. So these are converting the hepatocytes into lipoproteins that are utilized for the body. And it also acts as a storage of fat. So fats are also stored within the liver or transport the liver and then can be converted into energy for later use. And so bilirubin detoxification. So that those red blood cells, so hemolysis of erythrocytes. So that's the breakdown of red blood cells. So the spleen is also involved in this hemolysis of erythrocytes, or the breaking down of the red blood cells into some of its components. So when red blood cells are damaged, they need to be broken down and recycled, the components of it and parts of it. So it's broken down by these reticular endothelial cells. So that hemoglobin is broken down into the heme and the globin portion of it. So that heme part has iron and bilirubin. So this bilirubin is called uncoagulated. We follow that transport chart. Blood is transported and bound to that albumin that's produced by the liver. It's brought into the liver hepatocytes, and the liver separates the albumin and the conjugated bilirubin. And then the liver then will get rid of that bilirubin and secrete it into the bile ducts. Elevation of serum bilirubin. When there's excess bilirubin in the bloodstream, it leads to the jaundice. And it ideally is going to be exited and secreted via the biliary tree into our digestive system, and then we just pass it through our digestive system. Basically defecate it out. We poop out that those dead red blood cells. Amino acids are recycled like that.
I'm something of a karaoke connoisseur.
Hello, in this video, we will study about the bilirubin metabolism. The bilirubin metabolism begins with the red blood cells, which have a lifespan of approximately 120 days. And after they complete their life cycle, they are destroyed in organs like spleen and the liver, which contain numerous macrophages. So it releases the hemoglobin within the red blood cells. The hemoglobin is then split into the heme component and the globin component. The globin is further converted into the amino acids and utilized in the body. The heme component is then converted into the iron and the biliverdin, and this reaction is catalyzed by the enzyme heme oxygenase. In the next step, the biliverdin is converted into the yellow compound, the bilirubin, and this reaction is catalyzed by the enzyme biliverdin reductase. This bilirubin so formed is in the unconjugated form, which is not the water-soluble form. So it requires albumin for its transport to the liver. In the liver, the bilirubin is converted into the conjugated form, which is the water-soluble form of the bilirubin. And this reaction takes place by the combination of glucuronic acid with unconjugated bilirubin. It is then transported through the biliary channels into the duodenum, and through the duodenum it reaches the colon. In the colon, the bilirubin is acted upon by a number of microorganisms and is converted into urobilirubinemsin and stercobilirubinemsin. Majority of these compounds are excreted in the feces in the form of stercobilin, which imparts yellow color to the feces. But 10 to 15% of these compounds are reabsorbed into the blood, and some part of that reaches the liver, and this is known as the enterohepatic circulation.
Why is your poop
Few
brown?
percentage of the reabsorbed compounds reach the kidney, and they are excreted in the urine in the form of urobilin. So this was a brief overview of the bilirubin metabolism. I hope you find this video useful. Make sure to subscribe to our channel for further videos and also like our Facebook page for upcoming notifications. Thank you so much for watching.
You're welcome. Bilirubin detoxification. So again, it's kind of just breaking down what we were saying about like, red blood cells, they have a lifespan of about 120 days. When they become damaged, they need to be then broken down into its components. That heme and the globin part, heme is then further broken down. And that's what produces or gets converted into the bilirubin. And this is done in the liver. So in order to get into the liver, it requires that enzyme or protein, albumin, to transport that bilirubin into the bloodstream and then into the liver. Once the bilirubin is then conjugated in the liver, it's put into the bile ducts and then transported, through the biliary system into the duodenum, into our digestive tract, and then basically excreted out. So again, if there's any blockage, in our biliary system, the biliary tree, maybe they have gallstones or a stone in the CBD or choledochal cyst or, a clot skin tumor or something like that. That bilirubin is going to build up within the bloodstream. It's not going to be excreted from the body. And then those patients are the ones that wind up with jaundice. So the metabolism of bilirubin occurs in the hepatocytes. Bilirubin is separated from the albumin, probably at the cell membrane, and then it's taken inside the hepatocytes, where it's conjugated. The bilirubin molecule is combined with two glucuronide molecules, forming this bilirubin dichlororonide. It's then excreted. The bilirubin molecule actively is transported across that cell membrane into the bile caniculi, which are microscopic headwaters of the biliary system. The bilirubin is released from the hepatocytes, passes through the bile ducts with other components of bile, and is delivered into the bowel. So with biliary obstruction, the hepatocytes picks up the bilirubin and conjugates it with those dinucleonide molecules. However, it's not disposed of, so it builds up. That conjugated form of bilirubin is then transurigated into the bloodstream, with, elevated levels. Um. So we can measure two different levels of bilirubin. We can have the conjugated bilirubin levels as well as measure unconjugated bilirubin levels. So indirect acting bilirubin, which is unconjugated, may also rise slightly in patients who have biliary obstruction. But the direct bilirubin predominates. So this is the main one, is direct bilirubin level or conjugated bilirubin level is really what we're looking at to determine if there's biliary obstruction or was the one that rises in cases of biliary obstruction. The direct or conjugated form also predominates in hepatocellular disease. So when we have things like, cirrhosis or hepatitis, these can also be affected. So excretion of bilirubin is a step that's most readily affected when the hepatocytes are damaged. Therefore, the diseased hepatocytes continue to take in and conjugate bilirubin, but are unable to excrete it. In biliary obstruction, the accumulated conjugated bilirubin is then regurgitated back into the bloodstream. And that's why the patients wind up with that jaundice appearance, the yellow appearance, the yellowing of the skin, their eyes. So bile. So bile is also an excretory product of the liver. It's also formed in the hepatocytes, so it's formed continuously by the hepatocytes. Collects in the bile caniculi adjacent to these cells. And is then transported to the gut via the bile ducts. So the principal components of bile, it's water, bile salts, and bile pigments. Other components can include cholesterol, lectin, and proteins. So primary functions of bile we know are to emulsify or break down intestinal fats, and is the removal of waste products excreted by the liver. Function tests. So LFTs, again, this is part of standard lab tests. So when you go into the hospital or you're sick or you're getting a checkup by your doctor, when they do a blood panel on you, one of the things that they're going to test are your liver functions, looking for those enzymes that potentially could be elevated. So there are a number of lab tests that can help diagnose liver disease. So although the responsibility of correlating clinical and sonographic information is primarily that of the physician, it's important that the sonographer understands the entire clinical picture in order to effectively perform, our ultrasound exam. So understanding, what those elevated lab values might potentially indicate will help guide your exam, what you could potentially be looking out for. So this AST, this aspartate aminotransferase, this enzyme is present in the liver and heart cells when these cells are damaged. So we could see it elevated in alcoholic hepatitis. It's also elevated in patients with hepatic necrosis or infectious mononucleosis. There's significant elevation in our characteristics of acute hepatitis as well as cirrhosis. So this is one of the things when cells are damaged, we get this elevation of this AST. So again, just keep in mind, this could be patient had a heart attack, so we got damaged heart cells. It's also going to be present in their bloodstream in those cases or those instances as well. Um, Another enzyme is going to be this ALT, this alanine aminotransferase. So this one is an enzyme found in the liver and kidneys, and it's released when the liver is also damaged. This one remains in the bloodstream longer than the AST. So it's slightly elevated in acute cirrhosis or when there's hepatic metastases, as well as in pancreatitis. Mid to moderate increase is seen with obstructive jaundice. And then there's a moderate to high levels seen in hepatocellular disease and infectious or toxic hepatitis. So LDH is lactic acid dehydrogenase. So enzyme that helps produce energy, present in almost all tissue, and is released in response to cell damage. This one can increase due to cellular injury and death. If it's mildly elevated, this can be due to hepatitis, cirrhosis, obstructive jaundice. It's moderately elevated. We can see this also in infectious mononucleosis. Primary use and detection of myocardial or pulmonary infarction as well. So this, this enzyme is one of the markers that we can see when patients have had a heart attack or some sort of pulmonary infarct. So alkaline phosphate or alphosphate. So this enzyme helps to break down proteins in the bloodstream. So elevated levels of alphosphate are a good indicator of intrahepatic or extrahepatic obstruction, as well as hepatic carcinoma, abscess, or cirrhosis. Levels are moderately elevated in patients with hepatitis and cirrhosis. So again, this alphosphate is a real good indicator for, biliary obstruction. So whenever I worry about someone with any sort of like gallstones or acute cholecystitis or some sort of biliary blockage, I look at that alphosphate to kind of give me a good indicator that, all right, there might be something going on. Again, we can also see it, patients who have cirrhotic liver disease, as well as hepatic carcinoma cancer. So with bilirubin, we said we can look at the two components, look, before it's conjugated. And then the conjugated portion of it after the liver's processed it. So that unconjugated is seen elevated with increased red blood cell destruction. So that would be, you know, maybe someone who has sickle cell anemia and they're in a sickle cell crisis. Maybe trauma from a hematoma or hemorrhagic pulmonary infarct. These patients have that elevated indirect unconjugated bilirubin levels. If the conjugated or direct bilirubin levels are elevated, then this typically indicates obstruction of the bile duct. So it's making its way, it's in the bloodstream, it's getting to the liver, it's being conjugated, but it's just not, you know, working its way out of the system. It's not being, you know, passed through the bile ducts and into the digestive tract. It's getting blocked up and backed up somewhere. So that's what's causing that elevation of that direct conjugated bilirubin. And then that's usually due to some sort of blockage, you know, in the biliary system, maybe a stone blocking it, or a neoplasm compressing the ducts, blocking the ducts. Again, we can think pancreatic cancer, head, the mass of the pancreas, clot skin tumor, things like that. And then we can also look at the total bilirubin levels. So these would be elevated in patients who have hepatic cancers, metastases, hepatitis, lymphoma, cholestasis. So gallbladder isn't contracting properly, or we get stasis of the bile within the bile ducts, secondary to drugs. Cirrhosis may also cause elevation on both direct and indirect bilirubin. But total bilirubin looks at both of those, you know, combined. The part of those liver function tests, we also assess the prothrombin time. So we said prothrombin is a protein produced by the liver that helps the blood to clot. So prothrombin time, the time it takes for the blood to clot. So that prothrombin time is increased in the presence of liver disease with cellular damage. So cirrhosis and metastatic disease can cause prolonged prothrombin times. Albumin and globulins. So albumin, again, is a protein produced by the liver that controls this colloid osmotic pressure. So basically it keeps fluid from the blood from leaking out into the surrounding tissues. So decreased albumin is seen in patients with hepatocellular damage. So patients who have, you know, cirrhosis, hepatitis, the liver's damaged, it's fibrotic. We have decreased amounts of albumin, and that's what leads to the development of the, you know, the abdominal ascites, the fluid that we see within the abdominal cavity, the swelling of the extremities. Patients with chronic liver disease show an elevation in gamma globulins. So gamma globulins are part of the blood plasma that contains antibodies. A little chart showing breakdown of some of the lab markers, or some of the things that we look for on those liver function tests. alpha fetoprotein we'll start discussing when we get into malignancies and cancers. So mainly, hepatocellular carcinoma. One of the ones that will raise these, alpha fetoprotein levels. But you got your alkyl iron phosphate. So that alpha phosphate has very good indicator for biliary obstruction. After we'd see it with patients who have obstructive jaundice. Phosphate, alanine aminotransferase, you can see with cirrhosis, hepatitis, biliary obstruction, malignancy. Elevated bilirubin levels, so we can look again at the total bilirubin levels, the direct bilirubin levels. Again, if it's the direct bilirubin levels that are elevated, that's typically, a good indicator of biliary obstruction. The prothrombin time, then the time it takes for blood to clot. For a normal range, about 10 to 15 seconds. When patients have, liver damage, cirrhosis, hepatitis, malignancy, those clotting times will rise. Sonographic evaluation of the liver. So when we're doing an ultrasound for the liver, what we're looking for. We're looking at the liver itself, we're looking at the parenchyma, the tissue, assessing echogenicity, echotexture, the brightness of it. Looking for lesions within it, so cysts, masses, metastases, irregularities to it. We could be looking for areas of infarct, damage to it, hematoma, subcapsular hematoma. So we're assessing the tissue itself. We're also looking at the bile ducts. And then when we do the liver, we always assess the gallbladder as well, Patients could be status post cholecystectomy, so they may not have a gallbladder. In those instances, we just kind of take a dedicated image of just the gallbladder fossa to kind of just show where the gallbladder was, Sonography can detect anatomic changes associated with hepatocellular disease in conjunction with other diagnostic information. So the size of the liver, the echogenicity, the echotexture, is it homogeneous versus heterogeneous? Does it have a coarse echotexture or is it nice, smooth, homogeneous? We take that information, we combine it, with the patient's signs and symptoms. Are they having epigastric pain? Are they having postprandial pain? Is there a palpable mass that they're feeling? What's going on? We look at the lab results. What are the lab functions? The LFT's telling us. For sonographic evaluation, so typically patients are going to be NPO for at least a minimum of 6 hours to eliminate bile gas and to ensure fullness of the gallbladder. Patient positioning. Patients are going to be supine, right anterior oblique, decubitus, usually with deep inspiration to allow the liver to move inferior into the rib cage. When we do a complete survey, we're assessing the transverse. We can come coronal, intercostal, oblique, as well as in sagittal views. So again, we have to image the liver in multiple scanning planes. You guys are doing that. So when we're, again, assessing the liver, we have basic instrumentation should be adjusted. So we want to adjust our TGCs. Particularly, when the liver's being liver's a very large organ. You guys are nice and young, you got, healthy livers, so that sound, those sound waves can pass, fairly easily through the liver because it's such a highly vascular structure and it's full of blood. But patients who have, cirrhotic liver disease or fatty liver disease, that sound wave really attenuates and you lose the strength of that sound as it's passing through the liver. So that, posterior portion of the liver might not, the sound waves might not get there very efficiently. So we have to adjust our TGCs and increase our TGCs in order to see that, deeper posterior portions of the liver. You want to control your overall gain, you don't want it too bright, too dark. You might have to play with your transducer frequencies and types. You might have to switch, to a lower frequency transducer, lower your gain, lower your frequency in order to scan deeper, control your depth and focal zones. So we're looking for, again, the size of the liver, our sagittal plane or longitudinal plane, the attenuation of the liver parenchyma. So, can we scan all the way through this liver, or are we getting an attenuation of that sound beam where we can't see the posterior aspects of it? Do I see the vasculature? Can I differentiate, the vessels and the bile duct? Can I see that intravasculature within the liver itself? Because again, as things become attenuated, we lose the strength of that sound beam. We start losing visualization of our vasculature within the liver. The texture of the liver, is it coarse or is it smooth? Is it echogenic or is it, isoechoic, to the pancreas or to the kidney when we do our liver to kidney comparison? Like I said, do we see the presence of hepatic vascular structures? Do we see the ligaments and the fissures? Then as the liver starts to get disease, these things start to disappear on us and become harder to visualize. The liver texture, is it nodular? Do we see any nodularity to it, or is the walls of the liver nice and smooth? So we know that the hepatic veins are thin walled. The portal veins are brightly reflective, so they have a lot of collagen in the vessel walls. The hepatic, you can visualize the hepatic arteries and the bile ducts lie within the homogeneous parenchyma. With color flow Doppler, we want to look at the portal flow. So it should be a hepatopedal flowing into the liver, towards the liver. And the hepatic veins should be a hepatofetal flowing away from the liver. The normal echo texture should be nice, homogeneous, fine echo texture with low level echoes. So minimally hyperechoic or isoechoic when compared to the cortex of the kidney. Hypoechoic when compared to that echo texture of the spleen. So it's a little bit darker than the spleen. So here, pancreas is typically going to be the brightest when we were comparing these various structures. Spleen is then the next brightest. Liver is just slightly more hypoechoic to that. And liver is typically, particularly as we age, a little bit brighter than the kidney cortex. This is a good example, when we're doing that comparison, liver to kidney. You can see that the liver looks significantly brighter than the cortex of that kidney. And we can use that as, an indicator of fatty liver disease, fatty infiltrate. So again, as we're imaging this liver, We don't really see the vasculature that we would, expect to see, I don't see the portal veins, the hepatic veins as they're coursing through. We can see a little bit, so it's not, it's not terrible, we're not, have a completely cirrhotic liver, but we've definitely lost some of the visualization of that vasculature. And we can see a marked, increase in that echogenicity. Remember that the images are only a sample of what you've seen. If you miss the pathology, then it does not matter how perfect your images are. So again, just be cognizant and careful as you're scanning through the liver. Just slowly sweep through your organ, top to bottom, left to right, lateral to medial, all the way out. No. That's one of the things, like, I want you guys, when we were doing our sweeps, you guys were so focused on, looking at your structures or your landmarks. All right, I gotta take a picture here looking for that landmark. You really gotta just focus on the liver itself. You're looking at that organ itself. Those landmarks are just kind of telling the doctor, like, hey, I've been through this area, like, keep going, like, keep scrolling through that book. And you're just taking your representative pictures saying, hey, I've been here, it's kind of like getting your passport stamped in a way. And your focus should just be really looking at that liver, taking a step back and just assessing that liver and looking at it as a whole as you're sweeping through. So this is, sagittal left lobe of our liver. We've got our IVC coursing posterior. You can see a portion of the caudate lobe there with that IVC. Left lobe of the liver with the aorta present. Working our way out more lateral now. This is lateral now to the aorta. It's more right lobe of the liver now. So now we're angled out towards the right. And you can see difference between portal vein versus hepatic vein. It's very obvious. You can see the thick echogenic walls of the portal veins versus the thin walls of the hepatic veins are almost looking like it has no walls. Like I said, when you see portal veins sagittal, hepatic veins look more transverse, and then vice versa. Nice, we got our nice comparison picture between the right lobe of the liver, the right kidney. And with that comparison picture, we want to have a nice sharp, delineation or border between the two, to get a good image and visualization of that Morison's pouch. Again, there's a natural cavity or area, space between the right kidney and the liver where fluid can collect. So, particularly important for you guys in DMS when you're doing OBGYN studies and you're worried about like an ectopic pregnancy and a ruptured ectopic and they're bleeding out internally. If there's blood now filling Morison's pouch, that woman is like, needs surgery ASAP because blood's not filled that abdominal cavity. So that's one of the places where blood can accumulate, things like that. Again, ascites can build up in there, fluid can build up in there. Nice comparison picture. Morison's pouch, comparing the echogenicities between the two. Again, liver could be slightly more hyperechoic, but slightly brighter compared to the cortex, really depending on the age of the patient. Those of you, when you start scanning pediatric patients, the kidneys tend to be brighter than the liver. Transverse plane. Nice transverse image showing our hepatic vasculature. So this the hepatic veins that drain into IVC. So here we can see middle, left, middle, and right hepatic veins all in one image there. Transverse left lobe. So this is now more inferior. We could see caudate lobe, ligamentum venosusum. That separates the caudate lobe from the left lobe. See a portion of the left portal vein coming in, so it's not as clear as it is on some of you, but get the walls of that left portal vein as it's coming across. See more of the caudate lobe now, left lobe of the liver. Now when you angle down a little bit more towards the right. So we can see right lobe of the liver, the main portal vein, and then branching to that right portal vein. You can also see the IVC as we're angled out towards the right. And continue, inferior. So when we get into now, next week talking about, some of the classifications of liver disease. We are gonna talk about hepatocellular disease, so diseases within the hepatocytes, within the liver cells themselves. Versus obstructive diseases. So that affect bowel excretion that's blocked. So hepatocellular disease, the liver cells or the hepatocytes are the ones that are the immediate problem. They're usually treated medically with supportive measures and drugs. So examples of that could be, viral hepatitis. Versus obstructive disorders where the bowel excretion is blocked. These are usually treated surgically. So think like a stone lodged within the bile duct. Alright. Too bad. This helps.
Do you want us to just cross out the part that, they skipped over this weird chunk, I think it was just getting too in depth for the bilirubin and stuff.
Yeah.
It, yeah. I was talking about bottle.
Oh. I remember that for next week. The other part of it.
I'm adding your last mention. It's completely separate. At least you can think like what Jen says and the Brittany says now, not both gens overlap. You know what I mean? That's just, for gens, Joanne, it's Valerian pathology. That's, for this, it's just a little more. We just. Hard.
So D is right here. Like out there, detoxifies drugs and poisons, then enter the body. Poisons. I have a key to this too. Poison. Poison. Liver also manufactures plasma proteins, but it's under E.
Do we all miss this? Yeah.
Yeah, I did. There's fatty acid, converts amino acids into fatty acids is urea. There's nutrients from the blood. Phagocytizes bacteria. Beautiful. It's like there should be any part X'd out.
Yeah, I don't know why I missed that. I thought you were, when you're reading, we're reading it, maybe I thought you were like summarizing, I don't know. Maybe because it was blue.
It's blue, it's different from our.
Maybe it's all blue.
It was out of it. Hey, look, we don't have it, we don't have it anymore. I was really cool, like, we have that for every single class. Yeah. What's this? He's like, I always want some more.
Right.
Oh, definitely.
Or-
Don't mind
Oh crap, I need to shave. When you see yourself on Zoom, I look like a criminal or homeless.
Imagine I walked down, like, what is this girl?
Homeless.
I just wasn't a thought that came into my mind.
I was gonna do it this morning. I was like, you know what, I better leave. I
Yeah,
got my
because
son on
you
the
saw
bus.
me late.
I know.
Second later, you wouldn't have made it.
Let's see. Let's look at our test for this class.
Like. Okay.
I need to go get my flu shot too, to be honest.
Yeah.
Got mine, the lady was so shaky.
Oh, that's not good.
Kate. And no, it had to be like medication induced, cause she seemed like she was older, like probably like 60, she knew it, she literally was like completely,
Oh, I got my
completely shaken. Like
This is her
opening the
first
wrap.
time, like, Parkinson.
I tested her and they probably don't believe that, and she was like, bro, yeah. Like I could tell by her demeanor, she was there before, but I was like, this for sure. It was.
Where'd you get it done?
I don't know that.
I'm just glad I survived.
A couple days ago. Yeah. I did survive. and her arm was so sore. We did
Gotta
it
move
after, I
it.
was like, that's
Gotta
not
move it.
normal. It was from her, and like, I felt her when she put it in and was like pushing, I felt her shaking, I'm like, I hate that. Like, bless her heart.
I didn't eat like all day when I was doing the shots at the. I was shots at the unit and I was like, let me try it first, see what. Cause I didn't want them to like see. Feel good.
I do, you my school.
I shake all the like, what do you think? I'm like, don't shake that, shake more.
Alright.
I have to look away, I can't look at it, I like it. It's not that, I think it's fine with you, cultural. That was we're gonna do? Yeah. Yeah. Or check with them.
Yeah.
Oh, I just. Stupid. Yeah, exactly. Did you? I'm like, actually, I found my finger. I don't know. If the scanner hurts me, I will never. I think he'd be scared to do it, because he'd be scared you're gonna hit him. I'd be like, hurry up. Well, where you at over? I don't wanna get the liver inside.
Well, we're having our study group, late, so about that.
Depending.
Yeah, depending on what time you get back. A new cute jacket that I got for one of the can't wear. That's not for me.
Yeah.
That was on back order for 2 months. I couldn't wait because, let me show you all of these. She's different than the other drafting.
The what, Ruby?
She's cute for one, big wig.
With this?
She,
Yeah, like what?
you can like slim shirt, you can slim shirt.
Oh,
All the other ones didn't have to put their slim. And you feel it, like get into it. No, that's not enough.
So
Instructions. You ever thought, please?
the only labeling that I have is like the basic diagram that I gave the picture.
Back order makes sense, the healthcare really.
Yeah, hold on.
Amazon, I'm telling you, 5-star review. All the healthcare groups.
Content.
So like stuff in the, here, basically.
Yeah, just this one.
I'm feeling it. No, check it
Sexual
out.
resources.
No, it's small.
Oh, like,
It is better than yours. That's fine, we didn't
he
scratch
said
it.
it is better.
That's out.
Scratch it, supposed to scratch it.
Fine, black.
Okay.
Please feel this.
Sounds good.
You're telling me about it.
Oh my god, shut down.
Love it. No.
Guys, Thanksgiving is
Oh,
coming up.
yeah, I like that. That's a good picture. No one didn't give me that. I'm like, you're pleased to, right?
Nice.
Right, listening. I don't know who's off.
Wondering like.
It's kind of like.
Stop the diagram when I got it. Like,
Yeah, I know. I wanted to make sure I knew that. I don't think so.
Diaphragm, coronary ligament.
So good.
This is on there. This is on D12. It's on.
Get haircut.
It's under extra resources. So go to that go-to folder.
Alright, so we just know this, it'll be alright, state names.
For the labeling, yeah. So I have, that's basically, that's the picture I have. So go to that,
I missed it.
go to your D2L folder. Like the go-to one, and then under extra resources. The coloring labeling.
I love a good color.
So that one.
A sheet. Not a free draw color.
So coronary ligament, falciform ligament, diaphragm.
Think when you get extra credit, only you can color it in.
Color it in.
Is it only gonna be the anterior view of the liver or is it?
I was asking color, cause the workbook, I was like, I like.
Just like in an inferior view like that.
Well, sometimes when you study the liver, they
Well, that
take
one-
the regular orientation and they flip it up,
Yeah.
and other times they take it and they
So is that
turn
gonna
it
be on there
around.
too, or just the?
No, just this
So
one.
I'm like,
I was like, please don't.
because if you take the liver and you flip it up, then the gallbladder is like on the top, but if you take the liver, you turn it
Alright.
around.
What else should we study
I don't fucking know. I don't know.
Um,
On the bottom?
Like, I'm hoping for specifics, I've got a few others.
yeah.
Anatomy.
Yeah.
I know the liver, the lobes, the ligaments,
Study that
vasculature.
packet.
Lobes,
Yep.
ligaments, vasculature.
That packet.
Yeah, the lobes, the ligaments, the fissures, you know, segmentation, the vasculature.
Gallbladder fossa.
Functions, the tests and stuff?
Yep.
Okay, so it's just everything.
I don't
we
like the
just did.
LFT stuff.
And then this packet too. It'll be.
Yeah, what we
It'll be
just
okay.
did today.
Yeah, packet, perfect, great.
So like, you know, be able to break down the liver, like, the hepatic veins, middle hepatic vein separates right and left lobe. Left hepatic vein separates left lobe into lateral and medial, right hepatic vein separates right lobe into anterior, posterior, so comfortable with that. The flow direction, so, portal vein and hepatic artery, hepatopedal. Hepatic veins, hepatofugal. What's the name of the capsule that surrounds the liver? Gleason's capsule. Gleason's. Gleason's capsule. Some of the spaces, so Morson's pouch is where.
Between the kidney and the lid. The lid.
So if you go back like on here and actually go back and just refill in, you're gonna be
Yeah.
totally fine. Portal triad consists of,
Perfect.
it's gonna be a breeze.
It's literally this big.
What's Rydell's lobe?
Yeah.
Oh,
That's not female.
What?
I said, I feel like.
You have
you
it?
just give us this paper, I said, fill it in, that's it.
Never did that to us. Alright, so now I just need this outline for the other two classes, so everything's and we'll be good to go, literally.
Well, we have the one. Thank you. Yes, that's the person.
It's okay, we got this. I actually don't know. It's gonna be a rough week, I'll tell you that. Oh, yeah.
Why would it be a rough weekend? What will you make it?
Studying for 20, fine. That's not fun. Great.
Well,
I don't know, I study a lot, and I did not.
Think about all the
time.
people that are working their sorry ass jobs.
I
just
have
to
like
get after the program.
EDC or something, I can't.
Think about all the people that are like, wow, I have to reapply next year.
It's true.
Think about that.
Yeah,
That is true.
I'm like, I'm having a relaxing weekend.
You know, while you're stressed out this weekend in the program, they're stressed out about how they have to hire here. There's literally a girl at my job yesterday. She was like, I'm like, I don't know, it's a new girl, just talking to her tonight. She's like, yeah, I'm really looking into philosophy school. And I was like, you? She's like, but I'm 25. And I was like, so what? So am I. I really did. And then I was like, talk about it. I'm giving her the whole rundown. I'm like, our professors are great. And then I'm like, it's next year, the programs, it's a new building and new numbers and other changes.
Wait.
Wait,
Wait, when is that, next
Apply.
year?
Right, we'll be in the new
Summer.
building next year, or,
Hopefully summer.
I don't know if it's gonna be good or bad, like, I'm excited about it now, but what if we get there and it's not, like we thought it would be,
And then
we miss home?
Tomorrow, if we miss home now, like, actually.
There's a cafeteria there. So.
Oh,
So, but
Like it.
well, what if we have to NPL?
there's a gym.
That's gonna suck.
No, there's a gym?
Yeah, we use this as a.
Okay. Okay, well, it's in my membership.
I mean, you haven't, not been to that. So.
Doing chips.
So it's more of like a, like, hold on, college building, right?
It's-
I gotta show
I know,
you.
office building. Like, corporate office.
That's
building.
Just goes back. So we don't 10 minutes, right?
Yeah, between.
That would help, but like when there's late.
That's, like, what, we have an address, like, how far is it?
Avenue North, like, you could search up, it's like, yeah.
You literally just, oh.
Go to class.
Do they have whiteboards?
We have one in
Really
Anchorage.
study places in this new
Mhm.
building?
Oh, no.
Yeah, so like, it's,
Along.
I don't know how big the screen's gonna be, they told me it's gonna be like big screen televisions and like, yeah, whiteboards and stuff, so no more chalkboard for me.
Yeah.
Minutes away from here.
Yeah.
Oh, so it's
It's like right off the two oh two.
Building they just built there.
I'm gonna go creep on it.
So cute. You've seen it?
I'm walking around showing the badge, I'm like, I'm allowed to be here.
Okay.
Good in mind. You say. I'm like,
Yeah, right near AstraZeneca.
Yeah.
Walking around.
Probably,
That's
it'll
so
probably
planned.
be useful.
That's gonna be.
What floor are we on?
No problem, Tom.
No, I think we're, yeah,
Which one?
They're really putting us.
They're like
through
the
the basement.
I think we're on the ground floor.
Really? Oh, that's still.
Well, it's better than the basement.
Where's the gym ground floor as well?
Basement. Like one thing now.
The gym. Bye, guys.
It'll be safe, it'll be, you know,
Yeah.
secure.
Gosh, looks like that building. Would you guys own it or is it still renting?
No, it's, here? Yeah, we rent
I
this
know you rent
space.
this space, are you gonna rent that?
No,
space?
that's
That's
what
yours.
Chris Tree Man is building.
Oh, cool. Yeah.
They own,
That'd be
like,
sweet.
there was a lot of space that just wasn't being utilized, that
Yeah.
like. So like, oh, it doesn't make sense to pay rent if we own this darn building and then like.
Yeah.
if you guys-
I absolutely do. You ready to go find the lid?
I'm so excited, I'm ready to go.
The lid.
This is giving.
Delivery.
Which one's
Bye,
fun?
Queen. Bye. Everyone you want.
Bye.
I don't know.
We're doing our conference.
For vein mapping,
I guess I'll.
use the hockey stick. I'm telling you, you guys gotta get, anyone who didn't use it, I'm gonna tell. It's on the machine no one likes, and one of the corners.
Oh, practice on those. Or like skating. Alright. Are we still having this? Okay, it's Wednesday. They're gonna do comp and you're gonna do test. Next Wednesday, we're all, you're like really trying to take it out next week. We got a test in June and Monday. Then we got the right upper grade comp. Then we have the test one. And then on Thursday, the back.
And we have time in this class,
Just thinking about it.
so I mean, if you guys want, we can do another week.
We push the comp.
The comp,
What are we talking about?
What the right upper. Yeah.
another week.
Like just
So
put the
that's,
test
explain's
online.
easy, explains
Yeah,
like really
explain
4 inches.
Like, we'll do that.
Another week for the comp.
What do you think? Get in here on that.
What are we talking about?
Because we are supposed to have
So
our test
comment on
Wednesday
this
and our
next
comp Wednesday for the class. And we already have the test Monday, GYN, and we have our quiz Thursday, so I feel like we're just.
Yeah. I know there is a lot next week. I thought it was the vascular upper and lower extremity comp, the liver test and the OBGYN test. Is there another one?
Well, we have right upper quadrant comp next Wednesday.
Is that next Wednesday?
Yeah,
What?
yeah. We have two
Follow
comps next week and right now.
No.
We shouldn't have a vascular.
For the
So,
study.
when do we do the right? Oh, that's.
For
That's
November.
Wednesday.
Did you guys look into?
So we're doing the vascular comp this week?
We are.
Yeah.
Seven test next Wednesday and their comp. But being mapping.
Today.
Tomorrow. Oh, okay, I'm messing up I'm like today, tomorrow. I'm mixing it all up.
Right
Oh, so the
now,
quadrant's supposed to be next week?
Yeah. with
This
the
like,
test.
this.
Next
Another-
week,
It's gonna be like the
I
November
just,
too.
like, that's just too much.
Yeah, I agree.
I'm sorry,
I said this, like, next week with the 3 tests, and you'd be like, but we have our own too. We have like 3 tests lined up right before Thanksgiving, is it?
yeah,
I'm super fine.
and Thanksgiving and then it's finals.
Mm.
It's a weird breakdown to this semester, how we have Thanksgiving break and then finals week.
No, I hate it, 'cause I'm like, I don't know how I'm gonna study, so. I don't know, let's just get back there and scan, fuck it.
Too short.
I'll be back to you on that. Let me know what do we do and after.
They gotta come to you.
You know, that way we can focus on studying, because how are we gonna, we don't have time to like scan and also study, so one or the other. I would just go there.
Cause I'd rather have less time for swing and I feel like.
Yeah.
I don't think we really, yeah.
It's fine. Just gotta get.
Yeah, like,
you know,
you know, once you go find it, dude.
Yeah, I think a lot of us just need more time. like
You're
the
done,
others.
everything.
Yeah.
Spleen will be easy too, right?
Yeah.
You're just behind something.
Yeah.
You know,
Yes, it is like, literally 4 pictures.
So that's no problem. I scanned the left leg.
There you go.
It was good. It was just very unknown. And I have to say, like, behind the knee on the left, hard.
Yeah.
I need to practice that.
Okay.
Like, I feel like
It's just all
just
hurt.
awkward, really reaching, getting over there. Really did. I was like, this is good. I need to practice left leg. We don't practice left leg at
Who
school.
are you with?
I jumped around. I was with Vanessa
Yeah.
for, I feel like a majority, but I did go in with Mike, who's been there for a while, and then I went one with Amy too, and I actually saw blood clot.
Yeah.
Yeah, it's like the first DVT study I've ever seen.
Yeah,
And we
positive.
get in there and it was like literally, she found, like, she went right on the common femoral and then she's like, yep, there it is.
So too.
So, yeah.
I saw a
Like-
stent in the femoral vein, I got to and it's fully occluded. So there's no blood flow in the femoral vein, or like before the stent, or where the stent is placed.
You like to touch the patient or not?
Not with Amy, with Vanessa I did, but I didn't,
So that one-
not on the blood.
I used to like, when anytime I had a positive study, I would like, hold on, like I wouldn't say anything.
Okay,
And I'd see if they would notice and I'd like figure it out.
yeah.
You know, like, you know, or like just get a feel for it, you know,
Yeah.
they'd be like,
Yeah,
I could tell like they're like, what's going on? It's not prostate, I'm like,
yeah,
body.
yeah. She put it on and I was already like, as soon as I saw it, I was like, that's
Yeah, that's.
not there. She did like, normally that's not there.
Dilated.
Yeah. like, I just.
Okay.
Thanks.
Cool.
So,
Good to see when you start
It
seeing
was good.
pathology.
yeah, it was good to see it, like, I kinda expected, we were kinda talking like, oh yeah, everybody sends them in for DVT studies, and then this one's positive.
Famous
She's
last
like,
words.
okay, good thing you came in today, it's a very good thing you came in.
No, that's famous last words. I feel
Yeah.
like I'd always go in, look, it's gonna be normal. I put the probe down with Jesus.
Yeah.
I was-
Cause they're so used to seeing it, they're like, "Great, send them in, check for DVT.
Yeah.
Gosh, that has doctors there, right?
Yeah, they have vascular surgeons.
Well, though, because the doctor that was there, like doing reading, she didn't really want to see the patient if they had a recent surgery. So she wanted the doctor who did the recent surgery to actually see the patient. So they were kind of going back and forth.
Oh, it was an
whether it's
outpatient.
outpatient. Yeah, he came in, he just had like swelling, pain in his leg, and he was like, I better come in, and she's like, it's a very good thing you came in. But he didn't have